We looked at CDC recommendations for PrEP and PEP. We evaluated and managed drug-drug interactions. We looked at patients who experienced intolerable adverse effects and how to manage them. And we educated the patients on importance of lifestyle modifications. Now, when indicated, let's recommend immunization to patients living with HIV. Generally speaking, the immune response in people living with HIV is significantly lower. Even when the patients are receiving ART, the CD4 T lymphocyte remains significantly lower compared to people who do not have HIV. Even the B cell activation will be impacted by HIV, and this is most likely due to the persistent inflammation. Even in patients who have undetectable viral load, this inflammation persists. And in general, recommendations for vaccinations are similar in HIV patients, with the exceptions of a few contraindications in HIV patients, especially with CD4 count less than 200, because they will be severely immunocompromised, especially when it comes to live vaccines. In general, the data for vaccine effectiveness in HIV is very low, which has led to under-vaccination in people living with HIV. So we need to do a better job of vaccinating HIV patients. All right, let's take a look at immunization recommendations for commonly encountered vaccines. So in one column, we are looking at healthy people, in other words, people who do not have HIV. And then in the middle, we have people living with HIV, but in general, they are divided into two groups. One that are really immunocompromised, so that's defined as either CD4 count less than 200 or CD4 count less than 15%. And of course, less immunocompromised would be CD4 count of at least 200 or at least 15%. So first we have the inactivated influenza vaccine, which is recommended annually for everyone, including people with HIV. So, inactivated influenza vaccine is recommended for people living with HIV, regardless of CD4 count. The live attenuated vaccine, of course, is not recommended for everyone who is healthy. It is only for age 2 to 50. And it's even then it's alternative because of lower efficacy. But when it comes to HIV, because this is a live vaccine, it's actually contraindicated in HIV regardless of CD4 count. And this is the only one that's contraindicated in CD4 200 or higher as well. Next, we have pneumococcal vaccine. So most recently, we have PCV 15 and 20 on the market. So either of them are recommended for people living with HIV. However, if somebody gets the PCV 15, it's also recommended for them to get the PPSV 23 8 weeks later. If they do get the PCV 20, there's no need for PPSV 23, and that is including once they turn 65. So, once somebody gets PCV 15 or 20, they're good for life. They don't need to get anything else once they turn 65. The same is true if they get PCV 15 and they get PPSV 23 before age 65, then they do not need to get it again once they turn 65. Now, with hepatitis A and B, HIV is actually an indication to get these vaccines. In addition to HIV, in general, men having sex with men and people who inject drugs, as well as those who have cirrhosis and who are homeless. So if any of these apply to the patient, it's recommended to get the hepatitis A regardless of CD4 count. And of course, hepatitis B vaccination is extremely important in these patients because co-infection with HIV and hepatitis B virus actually increases the risk of mortality compared to having either infection as a mono infection. So, patients with HIV, Hep C, people who inject drug, cirrhosis, and men having sex with men, any of these are indications for getting the Hep B vaccine. For meningitis, we have the meningococcal vaccines. We have two different formulations, one that has serotypes A, C, W, Y, and then we have a separate one that has serotype B, and there is one under development which will combine all 5 serotypes in the same vaccine. For people living with HIV specifically, serotypes ACWY are more likely to cause meningitis, so it is recommended for these patients to complete a 2-dose series 2 months apart. And then because these people will be living with HIV for life, they do need to get the booster every 5 years. Whereas Men B is not really recommended specifically for HIV. However, if the patients have other indications such as asplenia or complement deficiency, then they qualify to also get Men B. For HPV or human papilloma virus, just like the general population, it is recommended up to age 26. And then between age 27 and 45, it is a shared decision making. For varicella, it's important to note that it is a live vaccine, so it is contraindicated if the CD4 is less than 200. So if the patient has severe immunodeficiency, it is contraindicated to give varicella vaccine. For people with CD4 greater than 200, it's a shared decision making. So, it's something that the clinicians should discuss with the patients to basically discuss, risk versus benefit to see if the patient is willing to take this. And lastly, we have zoster vaccine recombinant, which is an inactivated adjuvanted vaccine, and it is recommended in routinely after age 50, so age 50 years and older, regardless of CD4 count. Now here's back to this slide for pneumococcal vaccine. So this is HIV infection is one of the indications under immunocompromised persons. As I mentioned, regardless of age, once somebody's age 19 or older, assuming they have not received PCV, any PCV vaccines as part of childhood immunization, they do need to get either PCV 20 or 15. If they get 20, that's it. If they do get PCV 15, they need to get 8 weeks later, they can get PPSV 23. Now, if they happen to have already received PPSV 23, they need to wait at least 1 year since PPSV 23 and get either PCV 15 or PCV 20. Okay, but ideally they should get the PCV first and then PPSV 23. That concludes this presentation.